Welcome to this program entitled Refining Clinical Pathways in the Rapidly Evolving Therapeutic Landscape of Advanced Non-Small Cell Lung Cancer. My name is Dr. Mark Sosinski, and I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida, and I'm also a member of that institute's thoracic oncology program. Here are my faculty disclosures. Our learning objectives today are to describe the importance of testing patients with advanced non-small cell lung cancer for key actionable drivers and mutations, as well as PD-L1 expression, evaluate the current landscape of non-small cell lung cancer treatment options and the potential impact of recent advances, and integrate efficacy and safety data, indications, and cost utility of newly approved therapies to optimize their placement in clinical pathways for non-small cell lung cancer. Well, here's the big picture with lung cancer. It is the most common, or one of the most common causes of cancer in the world. Worldwide, 3 people die from lung cancer every minute. You can see in the bottom, you can add up the number of deaths from colorectal, breast, and prostate cancer, and is still overshadowed by the number of deaths we see from lung cancer globally. This slide just briefly summarizes the current standard of care at diagnosis. Cord needle biopsy or fine needle aspiration is absolutely necessary for initial diagnosis and procurement of tissue. Non-small cell lung cancer, we've learned, particularly the adenocarcinoma subset, is very genomically diverse. And so comprehensive genomic testing at initial diagnosis is not an option. It is the standard of care in this population. PD-L1 testing also is the standard of care, but I will remind you is meaningless until genomic results are known. And with regard to genomic testing, as we'll highlight here, both tissue and plasma are complementary in defining this. So this, as I mentioned previously, molecular profiling is absolutely needed to properly treat non-small cell lung cancer. And this is why. This is a patient of mine. You can see to the left, this was her baseline CT scan. You can see on the left chest, a lot of fluid around the lung and a mass in the lung. She was quite symptomatic. We diagnosed her with an EGFR mutation by doing comprehensive testing. We placed her on the appropriate targeted therapy, in this case, osimertinib. And you can see 4 weeks later, she had an amazing response and felt dramatically better. And this is a very nice example of personalized medicine, targeting the right disease with the right treatment for the right patient at the right time. Traditionally, our therapies have included all patients and not selective patients. Our goal with using molecular diagnostics is to identify patients, shown in the bottom cartoon here, with specific molecular, histologic, or patient-related factors in which you can personalized therapy by pairing the treatment to them. It will improve outcomes, improve response, and this individualized approach will again get the right treatment to the right patient at the right time. You can see there are a number of testing platforms or test types for molecular testing, shown to the left, karyotyping, in situ hybridization, PCR, next-gen sequencing, immunohistochemistry. I won't go through this slide in detail. They all have their place for the right type of test. I think what we'll focus on today is really broad-based testing, which is best done by next-generation sequencing, which is probably the most efficient use of tissue. And because it's broad-based, we'll cover all the appropriate targets in advanced non-small cell lung cancer. And again, this slide brings it home. This is a very famous trial in lung cancer published about a decade ago. And this took patients who had Asian ethnicity, were never smokers, and had adenocarcinoma, and treated them all either with gefitinib or carboplatin and paclitaxel. And you can see that even though phenotypically these patients were all similar, they were not similar with regard to their EGFR mutation status. The EGFR mutation rate was 60% in this population. And you can see to the right the most important lesson, that even though these patients were phenotypically fitting the bill for benefit of an EGFR TKI, if they did not have an EGFR mutation, the green line gefitinib was highly ineffective therapy, whereas to the left, if they did have an EGFR mutation in that and got a EGFR TKI, you can see the green curve was superior to chemotherapy. And this really began a journey that we've been on now for about 16 years. Remember, EGFR mutations were first described in 2004. And you can see in the adenocarcinoma subset shown to the right that there's a growing list of molecular alterations, either mutations or fusions or amplifications, that have implications with regard to therapy. Many of them have FDA-approved therapies, which we'll discuss briefly here. You can see here the drugs that are listed. Many of these are approved by the FDA because of their high response rates and the durability of those responses. And again, I think this list will keep growing, and you can see the prevalence. The most common targetable abnormality we see is the EGFR mutation. However, even those that are listed in the 1% to 2% range, again, the goal here of a medical oncologist is to get the right treatment to the right patient at the right time. And here's a very nice slide that I like, looking at waterfall plots of targeted therapies in molecularly targeted patients. And these waterfall plots show that whether you have ROS1 or RET or NTRK or HER2, if you have a targeted agent against that molecular alteration, you can see that the vast majority, if not all the patients, are responding with decreases in tumor volume, often which are very durable. So this should be an inspiration to make sure that you do comprehensive testing to find these abnormalities at the time of initial diagnosis. It makes a difference. This is a survival curve from the Lung Cancer Mutation Consortium version 1. The goal in the lung cancer mutation study was to genotype 1,000 cases of adenocarcinoma. If you found a actionable alteration, ideally those patients should receive targeted therapy. And this reminds us, when we look at these three survival curves, that the two curves that are labeled no targeted therapy or no driver actually did inferior to those patients who had a target and got targeted therapy. So you can significantly influence the survival of patients by making the diagnosis and making sure they get the appropriate targeted therapy. And again, another example of a large number of patients who were diagnosed with an EGFR mutation, either those that received an EGFR inhibitor or those that did not. You can see a clear difference in the overall survival experience for those particular patients. And this is a rather sobering slide because this looks at a number of molecular alterations, and this is genotyping rates. And you can see that although we're at 60–70% for EGFR and ALK, we are woefully inadequate to the right with a number of these other actionable alterations. Now, this is data from 3 years ago. I think we're doing better. My argument is that all of these should be at 100% in every patient with advanced non-squamous, non-small cell lung cancer. Now, another option we have is so-called liquid biopsy or plasma-based testing. We do know that tumors do shed circulating tumor DNA into the blood. It is accessible with a simple blood draw. We have a number of techniques shown to the lower right. In the interest of time, we don't have time to review all of them today, but the take-home message here is that plasma circulating tumor DNA is an alternative to tissue-based testing and actually is complementary. This is a very nice trial called the Nile trial, which was a blood-based assay versus tissue. What they did is ask physicians to do the tissue typing that they would normally do. In addition to doing the tissue typing, they added circulating tumor DNA analysis with this blood-based next-gen sequencing platform. And you can see that there were 20% more patients detected with plasma-based testing compared to tissue. So this is a really important finding because we don't want to miss any of these actionable biomarkers. And the other advantage of the blood-based approach is that the median turnaround time was significantly faster with blood-based testing versus tissue-based testing here. So an important message there. Now, this is the cancer immunity cycle. We realize that starting at number 1, cancers are different than self. They have an increasing number of mutations. These mutations lead to neoantigens. These neoantigens are shed in the process of apoptosis and cell death. They should be recognized as foreign antigens presented to our immune system. We should be able to generate a response, traffic those T cells to the tumor, and kill the tumor. And we know that this can happen. You can see there are a number of steps here that are of interest with regard to targeting or reinvigorating the immune system with new therapies. And I'll just quickly look at them here. The two most common ones are using anti-PD-1 or PD-L1 or anti-CTLA-4. Now, the first demonstration of the utility of anti-PD-1 treatment was shown here in Keynote 024. This was a select group of untreated stage 4 non-small cell lung cancer patients who had a PD-L1 tumor proportion score of 50% or greater. Good performance status, activating EGFR mutation or ALK translocations were excluded, no untreated brain mets, and no contraindications to immunotherapy. You can see that control arm is a platinum doublet chemotherapy for 4 to 6 cycles. That was the standard of care. You can see in this high expressing PD-L1 positive population, the investigational arm was pembrolizumab. We know that the key primary endpoint was progression-free survival. Overall survival was the secondary endpoint. What I show you here is the updated overall survival analysis looking at this population. And obviously, the pembrolizumab arm in green was far superior to the chemotherapy arm shown in maroon, a median survival of 26 months versus 14 months, a hazard ratio for overall survival of 0.65, and the 3-year survival was nearly doubled with pembrolizumab compared with chemotherapy. Now, last month at the virtual ESMO Congress, we had the 5-year update, and you can see that this difference in survival is maintained. The hazard ratio now is 0.62, and you can see again about a doubling of the 5-year survival rate at 60 months. So 32% of patients with high PD-L1 expression receiving pembrolizumab were alive at 5 years. Now we have a second agent, in this case, atezolizumab. This is the Empower 110 design. You can see that these were very similar in their design, chemotherapy naive, good performance status patients, again, randomized for the control arm of non-squamous or squamous histology-based chemotherapy shown there versus atezolizumab with atezolizumab maintenance. Again, overall survival was the primary endpoint. And the first step in analyzing this was to look again at the high PD-L1 expressors, this measured by TC3 or IC3. We realize TC is tumor cell, high expression 3+, the IC is immune cell 3+. And you can see a very similar outcome, although certainly not as mature as the Keynote 024 trial, but a similar effect in these high expressors in favor of immunotherapy versus chemotherapy in this population. Now, just a word of caution in those patients who are less than 50%. This was the CheckMate 026 trial. Enrolled patients that were greater than 1%, although the primary endpoint was PFS among patients with a PD-L1 expression level greater than or equal to 5%. You can see to the left, the progression-free survival actually favored chemotherapy. There was an early dip in the Nivolumab arm in the blue there compared to chemotherapy. So that is a warning, in my opinion. And you can see to the right that there was absolutely no difference in overall survival. We recently had a second trial that addressed this population. Again, this is Keynote 042, a phase 3 trial of first-line pembrolizumab versus chemotherapy for PD-L1 greater than or equal to 1%. Again, you can see the key primary endpoints shown there, overall survival in the PD-L1 greater than 50, greater than 20, and then greater than 1%. You can see here the overall survival curves. If I draw your attention to the lower left, this was the greater than 1% population. This was statistically significant. The hazard ratio was 0.81. Almost half the patients in this trial were greater than 50%, and that survival curve is shown in the upper left. Now, again, very similar to Keynote-024, not quite as robust median survival numbers. In an analysis to look at a cut point shown in the upper right-hand side, you see greater than or equal to 20% seem to be the number. What we were really interested in is the exploratory analysis shown in the lower right, which is the TPS scores or PD-L1 expression from 1 to 49%. This was not statistically significant. Now, the other thing that you'll notice in all of these trials is that there's an early disadvantage for the immunotherapy arm compared to the chemotherapy arm. I call this the early dip. It's not a phenomenon you see when you combine immunotherapy with chemotherapy. And like I showed you on CheckMate 026, the same phenomenon was observed in Keynote 042, this early dip in progression-free survival for patients. And now we have 2 studies that included 1% or greater, in which there's this early disadvantage for the immunotherapy arm. Now, here are the results shown in table form. The only trial that I did not show you the data of was the bottom one, the Empower Lung 1 trial, using a different anti-PD-1 antibody. Again, you see, drawing your attention to the 4th column over, the overall survival hazard ratio versus chemotherapy. Are very similar from these 4 trials that evaluated this question. So certainly immunomonotherapy today, either with pembrolizumab or atezolizumab in the patients with high expression, is an option for these patients. I've said the first couple of bullets here. I will caution you that I mentioned the combination of chemo plus immunotherapy, which we'll transition to in a moment. In this population, there is a higher response rate associated with chemoimmunotherapy in the greater than 50% population. For patients less than 50%, I do not recommend immunotherapy alone for these low expressing patients. Certainly, treatment-related adverse events are lower with immunotherapy compared with chemo, but again, it's the early progression that I worry about demonstrated in these trials. Now, let's transition to adding immunotherapy to standard chemotherapy prior to what I refer to as the immunotsunami. Platinum-based doublets were the standard of care. They were histology-based, as shown. We often used bevacizumab was an option in non-squamous. And we standardly practice maintenance therapy with either pemetrexed or bevacizumab. The first trial to show here is Keynote 189. This simply grafted pembrolizumab onto the combination of either carboplatin or cisplatin plus pemetrexed, very commonly used regimen. Again, untreated, good performance status, first-line non-squamous, non-small cell patients. Patients with EGFR or ALK alterations were excluded. This is important to remember that. Again, all PD-L1 levels were allowed on this trial. We see here that the overall survival is improved by the addition of pembrolizumab to chemotherapy. You see a doubling of the median overall survival, and that's quite impressive with regard to this. The Empower 130 trial, again, the comment I'll make about Keynote 189 is that it used pemetrexed. There are some patients with non-squamous, non-small cell that have relative contraindications to pemetrexed. This trial was done with nab-paclitaxel in the non-squamous population. Co-primary endpoints, the same strategy, atezolizumab grafted onto that doublet platform. And you see here that both the co-primary endpoints of PFS and OS favored the addition of immunotherapy to chemotherapy, much like Keynote 189. Now, I mentioned bevacizumab. That's a option for some patients. This trial tested the addition of atezolizumab to the standard control arm shown at the bottom. That is an FDA-approved regimen of carboplatin paclitaxel plus bevacizumab for 4 to 6 cycles with the usual maintenance strategy shown here. Arm B was adding atezolizumab. Arm A was substituting atezolizumab. This trial looking at just the addition of atezolizumab, so a 4-drug regimen. You see progression-free survival improved on top with a hazard ratio of 0.59 and overall survival improved on the bottom Kaplan-Meier curve with a hazard ratio of 0.78. There were a couple of interesting subpopulations that were analyzed in this trial. The top is sensitizing EGFR mutations. They seem to be quite bevacizumab sensitive, and you can see that comparing the 4-drug regimen with the control arm, hazard ratio of 0.60. To the right, you see the comparison of the substitution of atezolizumab for the bevacizumab. So comparing the arm C with arm A, and you can see there absolutely is no difference. Same phenomenon with liver metastatic patients shown at the bottom. So these two populations of EGFR mutant patients who have exhausted their options on TKIs, remember they were excluded from many of the trials that I mentioned previously, or patients with baseline metastatic disease who are eligible to receive bevacizumab, this is a viable option for them. Now in the squamous population, we have Keynote 407. This used carboplatin plus a taxane, either paclitaxel or nab-paclitaxel. Again, good performance status, untreated stage 4 squamous patients. You can see here that maintenance therapy with pembrolizumab was allowed after 4 cycles. And again, the same phenomenon of adding immunotherapy to chemotherapy in the squamous population, as was seen in the trials that I just showed you. And again, I failed to point it out on previous slides in Kaplan-Meier curves, but you see no early disadvantage in any of the chemo-immunotherapy trials like we saw in the chemo or the immunotherapy alone trials. Again, PD-L1 is something that should be tested in all patients, but it's not a perfect biomarker. If the PD-L1 is less than 1%, we would refer to these as negative patients. I wouldn't exclude them from treatment. Here's an analysis of the PD-L1 negative patients from Keynote 189 as well as 407 and then a phase 2 trial 21G. And you can see that even with negative expression here, there was still clearly a benefit that looked very similar to what we saw in the PD-L1 positive population. What about IO alone options for these patients? Well, we recently had the 3-year update for CheckMate 227. This led to an FDA approval. A complicated trial, again, first-line patients, no EGFR mutations or ALK alterations. Population was divided into PD-L1 positive on the top, PD-L1 negative on the bottom. You can see on the top in the PD-L1 population, the chemotherapy alone arm was the control. Again, we don't use chemo alone anymore, so the control arm is not an up-to-date control arm. Nivolumab alone versus nivolumab plus low-dose IPI. In the PD-L1 negative population in the bottom, again, a chemo alone control arm versus the Nivo added to chemo or Nivo IPI as an option. And the primary endpoint of interest that was recently reported was the overall survival in the PD-L1 greater than 1% population. That is shown here. Overall survival to the left, progression-free survival to the right. You can see in both of these situations that at the end of the day, it was favoring immunotherapy, either Nivo or Nivo plus IPI. Again, I'll point out with immunomonotherapy, there's the early disadvantage to the immunotherapy alone patients that aren't getting chemotherapy. So something to be aware of in this population. Now, I do show you, this is not in the FDA label, but this is in the PD-L1 negative population. You can see here clearly also an advantage for the combination of nivolumab plus ipilimumab in this setting. An interesting trial that also led to an FDA approval is the CheckMate 9LA. This simply gave, again, the nivolumab IPI with 2 cycles of chemo versus chemo alone. Again, chemo alone is no longer considered the standard of care, so keep that in mind. The primary endpoint was overall survival, and we saw an advantage for simply 2 cycles of chemotherapy with Nivo IPI versus chemotherapy alone. So another FDA approval in this setting. Now, we won't spend much time on toxicity, but I will remind the audience that the spectrum of toxicity is quite significant. Basically, we're inducing an immune response to the tumor that sometimes recognizes self instead of the tumor, or in addition to the tumor. You can see that no organ seems to be spared in the body. Physicians need to be aware of this spectrum, to be suspicious that anything that's going on could be an immune-related adverse events. And recognize it early. Fortunately, you can see that most of the adverse events are grade 1 or 2 shown to the left. It's unusual to have grade 3 to 5 shown to the right, a little bit higher with CTLA-4 therapies versus PD-1 or PD-L1. But I think the take-home message here is recognize the spectrum, be suspicious, intervene early, keep them at grade 1 or 2 and prevent them from becoming grade 3 or 4, where you may have to discontinue the immunotherapy by itself. So again, I mentioned the term immunosynovium. This is a summary of the first-line FDA approvals we have had for immunotherapy in stage 4. I think I pretty much covered all of these trials in the short time that we had together, but certainly the landscape has become quite complicated in this setting, and one needs to be aware of all these indications to optimally manage your patient. Certainly, immunotherapy has revolutionized the treatment. We do have monotherapy options as well as combinations with chemotherapy. They clearly have improved overall survival. There are clearly subsets of patients with advanced disease that may derive great benefit from these combinations. Anti-CTLA-4, we talked about the CheckMate 227 and 9LA data. We talked about anti-VEGF therapy and Empower 150. The toxicity profile of immunotherapy is unique, as I mentioned, but it's manageable and uncommonly severe. PD-L1 is an established biomarker, but not a perfect biomarker. We clearly do need other biomarkers to help identify patients at the time of the diagnosis who are getting great benefit from immunotherapy. So I've condensed my approach to each patient in a relatively simple slide here. The first question I ask is, does the patient have a driver? If they do, I pursue targeted therapy. If no, is the patient a candidate for immunotherapy? If they're not, they have a contraindication, they get standard chemo. If they are, the second question is, are they a candidate for immunomonotherapy? These are patients with high PD-L1 expression, minimal disease volume, and minimal symptoms. And you can pursue immunomonotherapy with based on the Keynote 024 Empower 110. And then another question is, the patient a candidate for bevacizumab? If yes, then I use the Empower 150. If no, then it's one of the Keynote trials or Empower 130. So let's spend a few minutes about clinical pathways. You can see all the information that we just covered in a relatively short period of time is a lot of information. High quality clinical pathways should be detailed, should be evidence-based. You should treatment protocols that deliver cancer care to patients with specific disease stages and types. When these are used and designed and maintained, oncology pathways can serve as an important tool in improving care quality and reducing cost. Here are ASCO's criteria for a high volume pathway. The development should be expert-driven, should be transparent and evidence-based, patient-focused and kept up to date, comprehensive, and it should promote the participation in clinical trials. They should be clear in terms of its implementation and use, clear and achievable outcomes, integrated cost-effective technology and decision support, and efficient processes to adjudicate controversy. And then analytics. We should be transparent in reporting performance metrics. Our incentives should be outcome-driven, and it should promote research into care value and care transformation. Now, in full disclosure, I've been involved with the VIA pathways for almost a decade now. This is our pathway committee structure. You can see a number of different committees with different frequency of meetings shown to the left. I show this slide only to show the pathway determinants and how we make a pathway decision. Again, the intent of the VIA pathway is to get to one treatment platform for that patient. So efficacy is first. If there's a clear choice, this should that it's more efficacious for the patient, that should be the choice. If there's not a clear choice, then the question is, what are the toxicity issues? Is there a regimen or option that is less toxic? And if you can't distinguish them based on toxicity, then the third is cost. And this is only used if efficacy and toxicities are comparable. One should choose the lower cost treatment to both the payer as well as the patient. This is just an example of one of the pages in the pathway. This asks physicians, in the case of stage 4 metastatic non-squamous non-small cell, it asks them a number of questions about molecular testing. I started this lecture by saying how important this is. We are in the process of updating this to add the recent RET and MET indications, but you can see this queries the doctor, so the doctor has to think about, did I do it? And if I did it, what's the situation with regard to the test results? And we record that. Now, we actually did a study a couple of years ago looking at the use of a pathway like this, and I think I won't show you the data, but what I can tell you is that it did increase the rate of testing, and most importantly, it did shunt patients to targeted therapy when they had a target that was identified by comprehensive molecular testing. So again, it follows the getting the right treatment to the right patient at the right time. It starts with comprehensive molecular testing, and then obviously getting the right patient the right treatment. So my conclusions are lung cancer has become the poster child, both for targeted therapy as well as immunotherapy. As I've mentioned several times, comprehensive genomic testing is the standard of care. It is not an option. It is absolutely necessary for management. Tissue and blood-based testing are complementary, and if you find an actionable alteration, you must act on it and treat with targeted therapy. PD-L1 immunohistochemistry is important, but it should not be acted on until genomic information is available, as you can disadvantage the patient if you find that, for instance, they have an EGFR mutation and they have to get osimertinib after exposure to immunotherapy. It significantly increases the risk of an immune-related pneumonitis. And then lastly, clinical pathways are critical. As I mentioned, our goal is getting the right treatment to the right patient at the right time, at the right cost. And as you've seen here with lung cancer, it's become a very complicated disease to manage. And that's the value of the pathway in this setting. So our efforts are paying off. We've seen a decrease in the death rate. 2017 was the greatest one-year annual decrease in cancer deaths, which was largely driven by progress in lung cancer. So a very important observation in this setting. Lastly, we are in the middle of a pandemic here, and just some recommendations for lung cancer management at this time. We don't consider lung cancer an elective diagnosis. We also realize that symptoms initially are similar and they may overlap, so one has to have an high index of suspicion. Standard workup should proceed as planned. We've not delayed any of our tissue biopsies or anything because, again, there are lots of very good treatment options for these patients in this day and age. So we want to make sure that we get to a diagnosis and stage as soon as possible and then continue the strides we've made in treating advanced non-small cell lung cancer. So I want to thank you all for joining me this afternoon, and I'll be happy to answer any questions at this time.
Thank you. Dr. Czynski, we are here to answer some questions after following his presentation. Dr. Czynski, we have a few questions from the audience. The first one we have is, with multiple approvals at each targeted therapy class, EGFR, ALK, ROS, and RET, how would you weigh each FDA-approved agent for pathways, and what type of data is considered pathway changing?
Yeah, that's a great question. Obviously, we know the number of these mutants or fusions in non-small cell has been increasing, as have the number of drugs approved by the FDA. In almost all of these, we have multiple drugs approved. My experience has been with the VIA pathway, now the Elsevier pathway, and we make decisions based upon first efficacy, then toxicity, and then thirdly, cost. Obviously, with many of these agents, it's great to be first. We recently had the approval of capmatinib in the MET exon 14 and originated larotrectinib in the NTRK space. And, we've gone through the exercise when there's been a second drug, simply asking the question, does it appear to be more efficacious? Yes, no. Does it appear to be less toxic? And or if you can't make a distinction based on efficacy and toxicity, is it less costly? And we've made some decisions about the choice of drug on a pathway based on cost. We have a couple of examples in my tenure as the co-chair of the Lung Cancer Pathway Committee for VIA, now Elsevier. So that is a factor nowadays. But often you're in a situation where the first drug looks pretty good, the second drug looks pretty good, but it doesn't look better. And so we've been many times really have not changed the pathway when a second drug has come along, unless we have evidence, again, whether it meets one of those criteria. So I think that's the way it is. And I think we do have enough data among all these things to kind of make that efficacy, toxicity, cost decision pathway, if you will.
Great, thank you. Next question is about clinical trials, specific clinical trial. Do we have data from the IMpower 150 trial comparing ABCP to ACP in those with no driver mutations? They were wondering what the value is for the additional bevacizumab to a chemo or immunotherapy regimen.
Right, so, IMpower 150 did not directly address that question, okay? Let me start answering this question by saying, yes, we do have evidence that adding bevacizumab to chemotherapy improves efficacy. Bevacizumab in non-small cell lung cancer has 4 randomized trials, 3 of them phase 3, 1 phase 2, all of which met their primary endpoint. So the addition of Bev to a chemotherapy platform has been shown to have clinical utility in 4 randomized trials. IMpower 150 really took a bevacizumab platform and added atezolizumab to it, or substituted atezolizumab for bevacizumab. So it didn't really look at the addition of Bev, it looked at the addition of immunotherapy to Bev. There's much preclinical evidence to suggest that the combination of an anti-VEGF and an anti-PD-L1 agent would be additive or synergistic. The addition of atezolizumab to the bevacizumab combination in IMpower 150 met both its co-primary endpoints of overall survival and progression-free survival. So that is a valid strategy. Now, when you look at the direct comparison of atezolizumab to bevacizumab, there was no statistical difference. That analysis of IMpower 150 is currently in manuscript form, undergoing review, so that will be out there. But I did present that at this year's AACR meeting in July, I think it was. It was delayed a little bit because of COVID. So that's in the non-driver population. Interestingly, in the driver population, which was principally EGFR mutation positive patients, there was no difference between the atezolizumab and bevacizumab arms of IMpower 150. So if we do believe that bevacizumab adds to chemotherapy, like we believe that immunotherapy adds to chemotherapy. So there didn't seem to be any greater addition of immunotherapy compared to Bev. But the combination is actually the secret sauce, if you will.
Great, thank you. Carrying on, a follow-on question here about some trial data. Are HEOR study designs such as network meta-analysis and matching adjusted indirect treatment comparisons helpful in comparing data across trials?
Well, not necessarily my area of expertise, but, I think that one of the things that we're constantly taught in training is to not make cross-trial comparisons, because the patient populations can be different, and that mix of patients that gets into one particular trial may for uncertain reasons and unpredictable reasons may be different across clinical trials. So, I would think that those sorts of designs could be helpful. I do, but I still think we have to be careful with cross-trial comparisons because, it's likely that the patients entered onto these trials are not completely homogeneous populations.
Okay, thank you. What role should real-world evidence play in the efficacy, toxicity, cost discussions?
Yeah, I think it should play an increasing role. I think we have to get better at defining real-world evidence and how we collect it and how we use it. But we have to know that the outcomes that are demonstrated in well-controlled clinical trials where many patients would have been excluded from these trials for some reason based on either inclusion or exclusion criteria. And we know that many of us, when you have a new FDA approval based upon a phase 3 trial, that we do end up treating patients that are similar to the trial population, but not exactly the same. And so we have to get some real world evidence that the benefit that was demonstrated in the clinical trial is translatable to populations that were outside the inclusion and exclusion criteria for the trial. And I think the best way to do that is really to have a systematic approach to the collection of real world data that's meaningful. So I think it's it's a relatively new field, in my opinion. I think we have to get better at collecting real world evidence, but I think it can play a role in helping us. It's part of the puzzle, so to speak, of how we kind of make these decisions.
Okay, thank you. Do you find NGS results are returned on a timely enough basis to start therapy, or do you also test for EGFR and ALK separately?
Yeah, no, I mean, everyone would want information quicker. Okay, so, when you look at the standard of care nowadays, I do believe that the standard of care in advanced non-small cell lung cancer is comprehensive genomic testing. As previously stated, I test both tissue and blood because we know that we can find things in one or the other that we don't find in the other. And the greatest thing an oncologist can do is to diagnose an oncogenic driver in a patient with lung cancer, because targeted therapy is so much more efficacious in these populations than is chemotherapy or immunotherapy. Lung cancer is almost always lung cancer is almost never a medical emergency. It's almost always an emotional emergency. So this sense that you have to get started on something is overwhelming, particularly from the patients and patients' family point of view. I have discussions with my patients when I first meet them while we're waiting for comprehensive genomic results to say, there are really 4 buckets of treatment for advanced stage disease. There's targeted therapy in targeted patients. There's the use of immunotherapy alone in high PD-L1 expressors. Most of the patients get a combination of chemotherapy plus immunotherapy. And then the 4th bucket are those patients that don't have a target, aren't eligible for immunotherapy, so they get kind of old-fashioned chemotherapy. I say to my patients, my job as your oncologist is to get you in the right bucket. For me to get you in the right bucket requires for us to wait for the results of your comprehensive genomic testing, not only EGFR and ALK, but ROS and MET and RET and others here, so that I can get you in that right bucket, because we want our first shot on goal should be our most efficacious shot on goal. We know that not every lung cancer patient gets a second shot on goal from a therapeutic point of view. So it's critically important that oncologists get it right the first time, because that's where they're going to make the maximal impact on the survival of the patient.
Okay, thank you. Another question here regarding cDNA. Oftentimes we only have enough tissue for diagnosis, so rather than take time for biopsy to be examined and found to be insufficient tissue, should we actually send cDNA by plasma as new standard for genomic testing for swift results?
Yes, I think you should. I can cite many examples in my practice where I've gotten to see a new patient. They had insufficient material for tissue testing. We drew a plasma-based test, and we got the result of that plasma-based test, which showed an oncogenic driver before we could get the patient in for a scheduled tissue biopsy. And obviously, when you do that, if you find something in plasma, you can believe it and you can act on it, and therefore you can obviate the need for a tissue biopsy, which, again, comes with some risk sometimes, as well as the cost of doing that. People don't realize that the average cost of a biopsy in the United States is about $15,000.
Oh, okay.
And plasma-based testing is a lot cheaper.
Excellent. Thank you so much for your comments and for answering these questions, Dr. Cieszynski.